Thank you, Kevin. Welcome, folks. Welcome to this conference. Thanks for sort of making the time to be here to think about where we sit within the overall settings of our environment, our world, the health and care world that we're part of. And you'll notice that much of the conference is focused on skills and giving you the chance to look at clinical practice. But I'm going to say let's look at that bigger picture. Where do you, as clinicians trained in traditional Eastern paradigm of medicine, using primarily a form of acupuncture, and I say a form of, because if I say Chinese, those doing Korean acupuncture will say no, call it something slightly different, and those doing Japanese acupuncture will say no, call it something slightly different. So primarily using acupuncture as part of what we do as traditional Eastern clinicians. But I'm going to say, how do you change people's lives? Because that's what we do. And how do we, within our current system, look at what's going on and look at, therefore, the challenges our friends and we face within our communities, and therefore the opportunities for you as clinicians. So I'm going to sort of highlight 5 discussion areas. I'm thinking about the health and care context in the UK, some of the solutions that NHS England has proposed, and I'm going to deliberately talk about the NHS and the Western Orthodox solutions, because then it actually shows very clearly where we sit. And I make no apologies for talking about England. I know that the system is subtly different in the devolved countries, and subtly different again for our guests from across sort of Europe and across the world. But actually the demographic changes that we're facing and the problems we're facing within our communities are the same. So while I talk about England, actually when you think about it, it really can be very easily translated. I'm going to talk about the role of Eastern medicine briefly, but then I'm going to talk about as well what might be considered objections. I go out and talk to people within the health and care system. I go out and talk to groups of members locally, and the same sorts of objections sort of come up. Yes, but. Well, I'd like to talk about some of the yes buts, because I actually think it's a yes and we can do this. So that's a place to look at. And then I also would like to talk about some of the things that I have been encountering in the sense of real concrete opportunities. Because I think when we realise what we can do, then we can do it. It's a stepping point to actually taking our place within the system. So I'm going to talk about the demographics then first. So this first thing, you read the news, you see what happens on TV things. So much of this you'll go, yes, we know about this. There is an ageing population. That's a reality. If you actually look at the figures, it's quite surprising in the sense of, if you look towards 2020, the numbers of people ageing is significantly increased. In fact, there was a conversation about that at the AGM last night, for those of you that were at the AGM. Our population is ageing as well, so we're all part of the same dynamic. But the thing about ageing, and people tend to live longer, is that their health becomes more challenging for them. It's a reality we all face, that as we age, we have to start thinking about, there might be conditions that I have to manage. There might be more than one condition that I have to manage. So there's something about how do we look at overall health in a population that is actually requiring to look at more overall health. There's something about, and this the figure there about residential care really quite concerned me when I saw it. Many of our population end their lives in some form of residential care. The bit that scared me is if I'm at risk of going into residential care, it's going to be 2.3 years probably that I'll be sitting in that care home. That doesn't feel very comfortable. So what might we do around people's health at an earlier age to bring that number down and perhaps even get rid of it? Oh, and by the way, we're doing this in an ongoing financial squeeze, possibly made worse by some of the conversations this week. the news this morning about the overall credit rating of this country going down again. Whatever we believe about Brexit and what's going on, it is creating financial uncertainty. And that's going to impact on people's health. It always does. If you look at times of the times of recession, and you look at the pattern of health, the big unspoken word that you can't use at work, stress, affects people's health. And therefore we are likely to see not just an ageing population, but all those of working age starting to become less healthy. Is it all doom and gloom yet? So what has some of the NHS started to think about it? We've got things, if you look at the news around what people are saying, there is a belief that certainly this winter we will be under a level of stress into the system, the main system, that we've not seen before. That there are and there will be challenges getting people into and out of hospital. As Western care is based on waiting until people break and then fix them. So to do that, you take them through a system of primary care, then secondary care in hospitals, but that creates a situation where it all builds up. Primary care itself is really struggling. There's a waiting list to see a GP. Although I was in a conversation last night around the dinner table where I realised that some of you have long waiting lists as well, but I think that's for slightly different reasons, just because people are choosing to be working with you, as opposed to people going, I really need to see a GP now. So that system is failing. And then we get, not only is there this piece about people are staying a relatively long time within residential care, the amount of residential care is actually almost disappearing before our eyes, and it's to do with finances. So we've got an ageing population, they're struggling to get access to the Western healthcare system, the necessities of their failing health is pushing them towards care, and yet there is no care for them. So we are in a system that is actually in dire crisis overall. And some of the suggested solutions coming from the current system, in other words, it's coming from NHS England, they're setting up new models of care. Now this is based on a document called the 5-Year Forward View. Have any of you read the main strategic document of the NHS, which is the NHS 5-Year Forward View? No. Okay. Oh, hang on. No, there's a hand snuck up in the middle. This is essentially this identification of what I've just been talking about, of saying we are in crisis. So what might we do about it? And part of it is based around some redesign of the system. And a lot of that is about saying, how do we push care from a lot of money invested into hospitals and secondary care into primary care, your first point of contact with the health system. In my view, it doesn't go far enough. It simply talks about fiddling around with more GPs or more pharmacists or more ways of doing Western medicine. But at least they're thinking about it and aiming to do things. They're even thinking, and this is actually quite critical to us, there is a drive towards changing the way public money flows into health and care for the population. And it's called population budgeting, population-based budgeting. The way the system has worked for a long time is that someone here buys health and care services, so they are a commissioner, so they commission services. But if it all goes wrong, the commissioner can turn around and say, oh, not my fault, I commissioned these services and they didn't do their job, so they get away with it. So a lot of the time where health and care breaks down in an area, the commissioners may have done it wrong, but there's no way of holding them to account. So then we say, okay, so let's blame this provider over here, because they're doing the bit specifically, because we buy lots and lots of little services, they're doing the bit specifically for older people with problem with their right leg. Because we really fragment stuff in Western care. And maybe that little part of the system struggles because there's lots of people in their particular population with problems with their right leg. But we can't hold them to account if they fail because they say, well, actually, It's the people over there that's caused the problem. You put too much budget with them. So we take away the ways of holding people accountable. So if you're not accountable, why should you change, and why should you use different ways of working, and why should you consider a different paradigm of medicine? Because you're not accountable. So population-based budgeting says now what we'll do is we'll set a budget for this whole population. And we'll have one provider. Let's have this chap down here. He's responsible for the population of you, for your health. So now he's completely accountable. This one provider has to think about how do we provide the right services to enable health. And there's no excuse of, well, it was another service that got in the way. It's, no, you've got it all. Therefore, it pushes this provider to go, how do I keep people well in the community? Because it's the only way I can afford it on this budget. I can't afford to keep doing the current system because it will go wrong. We know it will. So by pushing this one provider to say you have to make it sustainable, which is our goal for health and care and wellness of our population, it pushes it towards people like yourselves that say we help keep people well at home, we keep people well in their communities. So it's a big shift in the pattern of how things work. Then we also have the other thing that's going on is the NHS and the health and care system has woken up at long last that patients actually should be making their own choices, and we should actually be thinking about the patient. And therefore, one of the key things about thinking about a patient is that a patient with long-term conditions, and there's that piece again, of most of us, as we get older, sadly, we are likely to get one or more things that we need to think about. But who runs the budget for you? Who controls what actually happens for you? Historically, it was your doctor. Or historically, it was you paying out of your own money. But they're moving towards a system of enabling people to have actually control over their budgets. So I can say, actually, I don't want to spend it on physiotherapy. I don't want to spend it on a knee surgical replacement. I want to spend it on my acupuncturist. Because actually that keeps me well the most. So things are changing. But the solution, if these are some of the solutions that our orthodox colleagues and our orthodox Western clinicians are thinking about, let's think about some of those things that will need. It's going to need a focus on giving the patient control over their own health. Because if we don't, we're still about fixing people. And it's still, the system will just run out of money. So we give people control over their own health. We need to focus on a total approach to wellness. It's very interesting talking to senior Western clinicians now where they talk about wellness and you can see them almost scratching their head and going, well, there's this word. It's well-being, it's wellness, it's this new thing. Is it really new? There's something, there's a focus on treating the whole person and their whole lifestyle. Because we know that it's about the holistic nature of the person that actually has the impact upon their overall health, their overall wellness. As soon as you've got overall wellness, you've got independence. Once you've got independence, you've got confidence. And all that stuff about the challenges of an aging population melt away because we enable people to remain confident. A focus on listening to what the patient needs and not what the clinical textbook tells you. And I think today and tomorrow is quite a lot about that. They're going to get all these different ideas and you're ready to go, well, hang on a minute, when I've got a patient in front of me, what do I actually do? Do I just go, there's the textbook? Or do I weave in something from different disciplines and different parts of our clinical paradigm to say that's the way of dealing with this person? So our Western Orthodox colleagues are starting to think this way. Isn't this the entire paradigm of what we do? Aren't I sort of saying this and you're all sitting there nodding going, well, we do that? So we are ahead of the sort of thinking that the NHS in England, but the NHS in Scotland, the NHS in Wales, the various systems out across Europe, the systems around the world. We're ahead of them because they're using Western thinking that is only just catching up. So, what about some of the objections you will hear? What about these bits where somebody says, yeah, it's all very well bringing in the Eastern way of working, the fact that you're using a different clinical paradigm, the fact that we're using acupuncture and different ways of using acupuncture to help people be well. There's some objections. Can't afford it. Larger population can't afford it, and certainly we can't afford to pay for you on the NHS. Not that I want you to be fully paid by the NHS, but a little extra income stream, or more importantly, recognition, would be really, really useful. Then you get this, I've heard a number of times, well, in fact, I've also heard doctors have even never heard of what we do, but that's getting less and less. But doctors saying to me, well, we can't refer patients. We're not allowed. It's against the rules. Can't possibly refer patients to you. No, they're, not allowed to. And then we get this, the final one, and it was big news last year. Well, because of the NICE guidelines, it forbids the use of traditional acupuncture. You must not. Now, I want to say a bit about that, because I think we can challenge that just slightly. Well, more than slightly. So let's start with some of these solutions. Well, I've already hinted at the changes that are coming to the budgeting processes. We can look at starting to be a recognised part of the system, and the system is starting to free up its own financial systems to be able to offer it as an income stream. And bearing in mind, at no stage am I saying here, there's a few of us work for the NHS, but the majority, and if I said show of hands, I suspect most hands would go up, you run your own business as private practitioners. Most of you, yeah. So I am not standing here saying let's get employed by the NHS, but I am standing here saying there's some interesting things will open up should we be recognised more strongly by the NHS, and that there are financial streams opening up that if I was sitting there running my business, I'd be going, how do I get my hands on a bit of that money? Because that's good business. So there's a piece around the larger population, it's opening up. Right, doctors cannot refer patients, it is not allowed. If you read the bit that goes on from there, I can summarise it in saying, and this comes from the General Medical Council. The General Medical Council is the rule book for doctors. If you break the General Medical Council rules, you are in trouble. And they quite clearly state in a document that is headed up delegation and referral, in other words, the rules of what you do about referring patients, they are allowed to refer to anyone on a PSA accredited register. Now, I'm making a bit of a guess here, but I suspect most of you are members of the British Acupuncture Council, because that's why you're here. Therefore, you every year do your CPD and your CPD returns, and you are on a register that is accredited by the Professional Standards Authority. Therefore, any doctor that is on the GMC can refer a patient to you completely within their own rules. So any doctor that says to you, I can't do that, you say, look at your own guidelines. Yes, you can. So there's one objection out of the way. And then I should go to the last one, which is the NICE guidelines. And we argued like Billy-O, I think is the phrase that I can say up here, about the low back pain guidelines, and that changed in a way that we were not happy with. But I am going to quote from that guideline. I am going to give you the first couple of paragraphs of it. Because you've all read that guideline, haven't you? You've read it in intense detail, including the first bit. The first bit that says this. The first bit that says it is not mandatory. You do not have to apply NICE guidelines when you treat a patient. You have to consider them, because that's their job, is to align out all the evidence. You have to consider them, and then using your own clinical judgment and the wishes of your patient and the patient's family and such like, you make a clinical decision how to treat people. That's from that guideline that we didn't like. Actually tells you it's not mandatory. Now, where they are used is in the commissioning of much larger services where you create an entire service that is part of the NHS public money system. But as I said, that's not where we sit. We sit as private practitioners. Therefore, we can use this to our advantage in some ways. Okay, so the system's not commissioning big services for particular guidelines that use traditional acupuncture. But we're allowed to do it. And I've heard people say to me, you cannot do this because the NICE guidelines say you can't. No, the NICE guideline gives you a guideline that they don't think it's the best form at this current point in time. It doesn't say you can't do it. And we know from our evidence and our own work that actually, in our experience, it is a useful way of treating people. So I'm just saying to you, don't get too caught into you can't do things. You can do things. And now I'm going to talk about some real opportunities. These are some of the conversations that I've sort of bumped into, I guess, over the last 12 months that we're progressing, we're looking at. I wonder how they might go further. None of these are cast in stone because things never are. So don't quote me that this will absolutely happen and then next year if it hasn't quite happened in the way we thought, you go, Paul, it didn't happen. We are working on making this happen. And the conversations I've had so far have been very positive, which is why I'm willing to share them with you and say, this is really interesting. So, the Professional Standards Authority, that group of people that accredit our register, which show that we are professional clinicians, and that cause the GMC to say to doctors, you are allowed to refer. We are working on I'll rephrase that. We have started work on one project and it's sort of morphed into two projects. And the idea is to give specific, the original idea was to give specific publications, but we've agreed it's more than that. It's about talking to GPs and helping them refer direct to you. So what leaflets do the GPs and the GP surgeries actually give to patients, and we'll be developing those in association with the PSA. What do the GPs actually have to say to people to do this? And the output and the agreed output with the PSA is that in those two areas where we're going to start this piece of work, that the members, the traditional acupuncturists, that are members of the British Acupuncture Council in that area will see more patients coming through their door. So the PSA are working with us. And think about it, if the clout that they have is when we make this successful, then we replicate it across the country. So there'll be a few of you, I'll be talking to you first, and then I'll be, this time next year, I look to be in a position to talk to more of you and go, actually, we're spreading this now. So directly asking GPs to refer to you. Then there is a piece. We are doing the evidence work. We're actually investing in projects that develop evidence. And again, I touched on it at the AGM last night. But things like the work that Naji Malik's been doing in Norfolk around evidence for PTSD and the use of acupuncture. These, I've started to seed these into the system, if you like, and saying this is coming along. And people are going, that's interesting. Tell me about it. So the evidence projects that we have set up will give us a really powerful tool for going forward. Interesting piece about, and the irony is that this is almost the topic of the NICE guideline that we all got so upset about, is MSK referral. So musculoskeletal problems, major headache in primary care. The GPs can't cope with it. It's very rare if you've got a back or a leg problem or a musculoskeletal problem anywhere and you go to your GP, the chance of you getting reasonable help is pretty much that size. It's not their expertise. So there's a recognition that you probably should go somewhere first before you go to your GP. If you stick with just Western thinking, that recommendation is probably a podiatrist if it's sort of like lower leg stuff, or a physiotherapist if it's anything else. They might, if they're really struggling, send you around to the local chemist shop to buy some pharmaceutical products. It is not necessarily the right thing to do. We're in conversation with NHS London at the moment, which is where this is going to be trialled. The thing that's going to be trialled is a triage system. So you've got your problem, you don't go to the GP, you phone up, and somebody goes through a set of questions and guidelines and then recommends where you go first. Physio, podiatrist, or actually you might be worth going to your GP, or your traditional acupuncturist. So if we're on that list, and we're in NHS London where they're trialling it, when it's successful, it will go nationwide. So the Western Orthodox system is not rejecting us, it's going, hang on, this is interesting. And then also, we're working with the National Association of Primary Care in their redesign of primary care to say, how do you weave British Acupuncture Council members into this? How do you weave in the paradigm of Eastern medicine into the primary care system in some shape or form? And I am absolutely clear, I'm saying to you, this is from what I see, this is not about getting more of you working directly for the NHS. This is about working alongside. This is about us being able to give the best, help is the right word, the best help to our community, to where we live, to the people we work with. And by doing that, from your perspective, it makes your businesses sustainable. Because if you haven't got a sustainable business, you won't be sitting here next year. So this is not just about, we have to always think about, we deliver health and care, but you do it in a way that enables your business to be sustainable. And the other bit about this is, I've talked a lot about here about being alongside Western Orthodox medicine, but this is also not about losing identity. This is about, we have an identity as traditional Eastern medicine practitioners, clinicians, traditional acupuncturists, from whichever branch of acupuncture it comes from. So, some thoughts about our outside world and our possible role within it that is enhanced from where we're sitting now. Done. No, yeah, that's lovely.